which shows up decision making.
Important key terms to know, guys. The forebrain is responsible for thinking and coordination. Contains the hypothalamus and thalamus. The midbrain is responsible for arousal and sleep, wakefulness. Neurotransmitters, this is important. It's chemical produced by nerve and it's released when the nerve is stimulated. It reacts with a specific receptor site to cause a reaction. The nervous system is responsible for controlling the functions of the human body, analyzing incoming stimuli, and integrating internal and external responses. Let's jump to page 332. Neurotransmitters. Again, they stimulate postsynaptic cells either by exciting or stopping them, exciting or inhibiting them. So these neurotransmitters, guys, you have to know. We're going to start with acetylcholine. Acetylcholine communicates between nerves and muscles. Norepinephrine and epinephrine. These are catecholamines, which are released by nerves. Guys, your epinephrine and your norepinephrine, these are your fight or flight catecholamines. Remember the story I told you about my bag getting stolen in Puerto Rico?
No.
I didn't tell you guys about that story. Oh,
Beat him up.
let me tell you guys what happened.
All right.
Why I am sitting here today and not in prison.
Where's the body?
So I was on vacation and Matthew, at the time, Matthew must have been like 6, 7 months old, right? I just came out of the Coach store and I bought a baby bag and I'm talking to my husband. All I see is a white skirt just rush past. And I realized I left my wallet on the counter. So I go in immediately and I'm like, I left my wallet here. And the guy at the counter is like, no, someone just, and it was the lady in the white skirt. I run out the store, I throw Matthew to my husband and I'm running. I'm chasing her now. Puerto Rico is very hilly. So she runs up the hill, I run up the hill. She turned the corner, I turn the corner. I'm telling you, if I caught her, I wouldn't be here today. But guess what? I ended up losing 40 pounds because I knew if I wasn't so heavy, I would have caught her. And I was like, this is never gonna happen to me again. Man, I must have chased her for 20 minutes until I ran out of oxygen. And when it happened and I realized that this lady stole my wallet, I had two choices. I could fight, which is what I wanted to do. That's why I was chasing her, right? Fight or flight, run away. These me chasing her, that's that epinephrine, norepinephrine that was running through my system that gave me that energy to chase her and eventually what I would have done to her if I caught her, but I'm safe now, so it wouldn't have happened. But the point is, you need to know that your norepinephrine and epinephrine, that is your fight or flight response. I lost 40 pounds after that. I came home and I said, if I ever have to chase somebody again, I'm gonna catch them. And I lost 40 pounds in 5 weeks.
Now you just chased
Whoa.
I know, right? Now I'm fat all over again, but let's not talk about that.
Now you just chased your kids.
I just chased the kids. That's right.
Never get away now.
Why did you lose that much weight?
I ran twice a day in the morning and in the evening, and I only ate fruits and vegetables.
Did
and
you ever
drank
go
water.
back to Puerto Rico for your training?
No.
After your training?
You want to know what the sad part is? Now that I'm thinking back, you know, sometimes you just make foolish decisions, right? Because now that I'm thinking back, first of all, I'm in an environment that I'm not familiar with. What if there was a van waiting for me around the corner that scooped me up and my husband, kid never saw me before? That's number one. Number two, the wallet itself was worth more than any money that was in it. When you go on vacation, by the way, guys, only keep $100 in one place at all times. So if you have $100 in your wallet, that's it. Then you don't have $100 in one shoe, $100 in the back pocket. Never have more than 100 in one place just in case something happens. So I'm chasing this lady over what? The wallet itself, you know what I'm saying? But you're not thinking.
But yeah, you're
That's how epinephrine does to you.
Yeah, all of that thing.
How do you get back?
No, I don't. There are very few countries, like if we're traveling, like somewhere like Puerto Rico, I wouldn't even have like my official ID. It would be in the safe, like with my passport.
Oh, you leave your ID at like. Yeah. I think my ID. What if the whole passport?
Yeah. So anyway, the whole point of that is just remember when you think of epinephrine and no epinephrine, think of fight or flight. Professor D chasing the lady in the white skirt.
Oh, Puerto Rico.
Dopamine. Dopamine is very important. NCLEX asked about it. Dopamine involved in the coordination of impulses and responses, both motor and intellectual. Patients that have Parkinson's have a decreased amount of dopamine. NCLEX expects you to know that. Okay. GABA, your gamma aminobutyric acid. This inhibits, it stops nerve activity, and it's important in preventing the overexcitability or stimulation, such as seizures. And then serotonin. Serotonin is your feel-good neurotransmitter. That's what I call it, feel-good neurotransmitter. All right. Serotonin is important in arousal and sleep and preventing depression and promoting motivation. When you guys haven't done psych yet, right?
No.
Okay, so when you do get to psych, you'll see SSRIs. Those are your first line treatment because that's the first type of meds you're going to try when it comes to depression. Okay, your serotonin is your feel-good neurotransmitter. So you guys have to know your neurotransmitters. Page 334. Key points. The nervous system controls the body. Very important for you to know. Let's jump to page 335. The midbrain. It contains cranial nerves related to specific senses, such as your sight, your smell, your hearing, balance test, and some muscle activity of the head and neck, such as chewing, eye movement, and the reticular activating system, your RAS, which controls arousal and awareness of stimuli and contains the sleep center. So your midbrain controls all of that. So the midbrain is very important. The forebrain. The forebrain, that's the upper level of the brain, guys, that contains the two cerebral hemispheres, your left and right, the thalamus, the hypothalamus, the limbic system. The thalamus sends direct information into the cerebrum to transfer sensations such as cold, heat, touch, and muscle sets. Areas of the hypothalamus are responsible for temperature control, water balance, appetite, fluid balance. Limbic system. This contains high levels of 3 neurotransmitters, which are epinephrine, norepinephrine, and serotonin. Stimulation of the limbic system, which appears to be responsible for expression of emotions, may lead to anger, pleasure, motivation, stress, etc. What did I write down here? Let's see what it says. I wrote this because it's not in the books, but it's not in the book. I couldn't find it, but NCLEX definitely asked you about it. The cerebral cortex hemispheres is responsible for speech, communication, thinking, learning. Your cerebral cortex, which contains your hemispheres, your left and your right, is responsible for speech, communication, thinking, and learning. Key points on page 337. The CNS consists of the brain and spinal cord, which are protected by bone and meninges. Summary, page 338. Important things to keep in mind. Efferent nerves take information out of the CNS to effector sites. So efferent is away from, okay? Efferent nerves takes information out of the CNS to the efferent sites. Afferent nerves are the sensory nerves that take information to the CNS. So afferent is information that goes to the brain. Efferent or efferent takes information from the brain. Got it?
Got it.
Okay.
We go back one page, just got one sentence you just said.
About the meninges.
Yes.
Right here, key points? No problem. You got it?
Yeah.
Okay. The CNS consists of the brain and spinal cord, which are protected by bone and meninges. To ensure blood flow to the brain if a vessel becomes damaged, the brain also has protective blood supply that's moderated by circle of Willis. The limbic system is responsible for expression of emotion, and the thalamus and hypothalamus coordinate internal and external responses and direct information into the cerebral cortex. The cerebral cortex, also in the forebrain, consists of the two hemispheres, your left and right hemisphere, which regulates the communication between sensory and motor neurons and are the sites of thinking and learning. Chapter 20, Anxiolytics, key terms you need to know. Anxiolytic, this is a drug used to depress the CNS. It prevents or reduces the signs and symptoms of anxiety. Hypnotic, it's a drug used to depress the CNS, causes sleep. All right, drug list. Number one on your drug list for next week. Your benzos, that's the first family of drugs you're gonna give me, your benzodiazepines. Notice most of them end in your lamb and your PAM. The one that you get questioned most often is your diazepam. Number two, your barbiturates, but these are used as anxiolytic hypnotics. Why do they have them both as the same thing? Anxiolytic hypnotics, anxiolytic, I don't know why they did that. But your barbitals, your phenobarbital, your pentobarbital, but the phenobarbital is the one that you get asked about the most. Number three, other anxiolytic and hypnotics. The one that they asked about the most, so I want you guys to give to me, is your buspirone. And your zolpidem. Make sure you know these two. I don't write NCLEX, guys. All I can do is tell you what I see the most of.
So,
The buspirone.
so I mean, for those two, you want those two cards for these?
No, just do one card for the both of
For the
them.
class, okay.
All right, so page 342, we're going to start with the benzos used as anxiolytic hypnotics. Benzodiazepines, the most frequently used anxiolytic drugs, prevent anxiety without causing much associated sedation. In addition, they're less likely to cause physical dependence than many other of the older sedative hypnotics that have been used to relieve anxiety. So the benzodiazepines used as anxiolytics include your alprazolam, that's your Xanax, your clonazepam, diazepam, lorazepam. Make sure you guys know these drugs and they fall under that class. Therapeutic actions and indications. The benzodiazepines are indicated for the treatment of the following conditions: anxiety disorders, alcohol withdrawal, excitability and agitation, pre-op relief of anxiety and tension to aid in balance anesthesia. And on the side here, I wrote makes GABA more effective. Because remember, GABA is good for slowing things down, right? It's good for preventing seizures. So it makes sense that this patient who has all this anxiety, they're like this, they're like this, they're like this, right? If it makes GABA more available, they're like this, which is what we want to see. Does that make sense?
Mm-hmm.
All right. You guys laughing at me?
No.
I see you, Vince.
No, because when I had surgery,
They gave you one?
yeah, I asked her.
Smart man. All right, the exact mechanism of action is not clearly understood, but it works. Contraindications and cautions to the benzos. Obviously, any allergy to any benzodiazepine. Psychosis. When you see that word psychosis, that means that the patient is out of touch with reality. Okay? Acute narrow angle glaucoma, shock, coma, acute alcoholic intoxication, pregnancy, breastfeeding. You're going to use with caution in the elderly or debilitated patients or any patient that has renal or hepatic dysfunction. All of the benzodiazepines now have a black box warning that concomitant use with opioids can result in profound sedation, respiratory depression, coma, or death. And it makes sense, guys, because opioids also do what? Slow everything down. So it's not a good idea to give opioids at the same time that you're giving benzodiazepines. Let's look at box 20.3. Special care should be taken when giving anxiolytic or hypnotic drugs to African Americans. About 15 to 20% of African Americans are genetically predisposed to delayed metabolism of benzodiazepines. Remember, metabolism is that breaking down and then absorption of it into the body. As a result, they may develop high serum levels of these drugs because it takes longer to break down, absorb, and get rid of, okay? With increased sedation and increased incidence of adverse effects. So you have to watch them much more carefully. You have to be careful. If an anxiolytic or hypnotic agent is a drug of choice for an African American individual, look at this, guys. The smallest possible dose should be used, and the patient should be monitored very closely during the first week of treatment. We don't want to accidentally provide them with a toxic level. The adverse effects of benzodiazepines are associated with the impact of these drugs on the central and peripheral nervous systems. Nervous system effects include, just think of everything that slows down, guys: sedation, drowsiness, depression, lethargy, blurred vision, sleep driving, and other complex behaviors, headache, apathy, lightheadedness, amnesia, confusion. In addition, mild paradoxical, remember that word paradoxical, what does that mean? Like ironic, right? The opposite of what we would expect to happen. Mild paradoxical excitatory reactions can occur. So even though this med's supposed to bring everything down, you might get a reaction where it actually brings everything up, right? That can occur during the first 2 weeks of therapy, so warn them. You have to warn the patient. GI effects: dry mouth, constipation, nausea, vomiting, elevated liver enzymes such as your ALT and your AST. Hematological conditions such as blood dyscrasias and anemia is possible. GU effects such as loss of libido or urinary retention. This is important, guys. Abrupt cessation of these drugs may lead to withdrawal syndrome characterized by nausea, headache, vertigo, malaise, and nightmares. Never DC abruptly. And guys, this goes across the board for all psych meds. The reasons are different depending on the psych med that we're talking about, but I promise you, if it's a drug that affects the CNS, you never stop abruptly. Patient must be weaned off. Drug-drug interactions. The risk of CNS depression increases if benzodiazepines are taken with alcohol. Guys, is alcohol a stimulant or a depressant? A depressant, so it makes sense. The risk of CNS depression increases if benzodiazepines are taken with alcohol or other CNS depressants such as opioids. So such combination should be avoided. This thing already acts as a depressant. You should not give the patient anything else that acts as a depressant, such as opioids or alcohol. The effects of benzodiazepines increase if they're taken with cimetidine, oral contraceptives, or disulfiram. You guys remember what disulfiram is? That's a drug that when you take this and you take anything that has even the smallest amount of alcohol in it, you get severely ill. Like you'll want to throw yourself off a bridge ill. And so it's used in behavioral therapy for patients who are trying to get off of alcohol addiction. So they can't even use mouthwash that has alcohol in it because they'll get severely ill. Okay, so with those three types of medications, you can't give benzodiazepines with because the benzodiazepine effect will be much greater. The impact of benzodiazepines may be decreased if they're given with theophylline. We've done respiratory, so you guys know the theophylline. Concept alert. When a benzodiazepine is inadvertently administered intra-arterially, arterial spasms can occur, which can lead to gangrene. Arterial spasms will decrease blood supply, which decreases oxygen, which can cause necrosis that can lead to gangrene. It's a horrible domino effect. All right, nursing considerations for the patients taking benzodiazepines. We're going to assess them for allergies to benzodiazepines, impaired liver, kidney function, any condition that can be exacerbated by the depressant effects of benzos, such as glaucoma, coma, psychoses, shock, acute alcohol intoxication, pregnancy, lactation. You're going to assess the patient's baseline status, assess their vital signs, monitor lab values, implementation and rationale. Do not administer intra-arterially because it causes spasms, which can lead to what? Gangrene. Very good. You're going to monitor the injection site carefully. Do not mix IV drugs in solution with any other drugs. You're going to give parental forms only if oral forms are not feasible or available, and switch to oral forms as soon as you can. If you do have to give an IV, how are you going to administer it? Slowly. Because remember, it slows everything down. You don't want to cause that patient to have hypotension, bradycardia, or even cardiac arrest. Arrange to reduce the dose of narcotic analgesics, because remember, our narcotic analgesics also slow things down. Monitor patients closely that are on benzos. Maintain patients who receive parental benzodiazepines in bed for a period of at least 3 hours. We don't want to fall, do we? Do not permit ambulatory patients to operate a motor vehicle after an injection. You're going to monitor the hepatic and renal function, CBCs. This is on NCLEX. You need to know this. You're going to taper the dose gradually after long-term therapy, especially in epileptic patients. Any drugs that affect the CNS, you can never DC abruptly. Rule of thumb. You're going to provide comfort measures, environmental control, such as lighting, temperature, stimulation. So this type of patient that's getting a benzo, are you going to want bright lights or dimmer lights? Dimmer lights. Are you going to want them next to nurse's station where it's loud and rowdy, or at the end of the hall? End of the hall. You're going to use safety precautions. You're going to make sure the side rails are up. You're going to make sure that bed's in the lowest position. You're going to make sure that the call light's within reach. And they know if they have to get up for any reason, they have to press the button for help. They should not try to get up by themselves. Okay, so case study, patients ordered Valium. What are you going to teach them? Make sure you teach them about the dizziness and drowsiness, nausea, vomiting, weight loss, constipation, diarrhea, vision changes. You're going to teach them to report any rash, fever, sore throat, insomnia, clumsiness, nervousness. Teach them to avoid over-the-counter medications. Anything over the counter, they have to talk to their physician first before taking it. Avoid alcohol while taking this drug. And of course, never, ever, ever stop this drug abruptly. They have to be weaned off. Key points. Anxiolytic drugs such as benzodiazepines depress the CNS to diminish these feelings. CNS depressants such as sedatives block awareness and reaction to environmental stimuli. So a patient on benzos, is that the type of patient that should be driving around? No. Includes drowsiness. Hypnotics react to Gaba inhibitory sites to depress the CNS. They can cause a drowsiness, lethargy, and other CNS effects. So you need to be thinking safety, safety, safety. I wonder, guys, let's jump back to page 340. Remember, I was so confused. I read it very quickly. This said benzodiazepines, and this said barbiturates. Yeah. You guys saw that, I did.
Oh.
All right, page 348. Barbiturates, used as anxiolytic hypnotics. All right, barbiturates, they were once the sedative hypnotic drugs of choice back in the day. Not only is the likelihood of sedation and other adverse effects greater with the barbiturates, the risk of addiction and dependence is also greater. And that's why we prefer the benzodiazepines and the barbiturates. For these reasons, newer anxiolytic drugs have replaced the barbiturates in most instances. The barbiturates used as anxiolytic hypnotics include, they give you the drugs, the one you better know. If you don't know any of them, you better know the Phenobarbital. And you better know that it's a barbiturate. Therapeutic actions and indications, barbiturates are general CNS depressants, so it slows everything down. Thus, they could cause sedation, hypnosis, anesthesia, and in extreme cases, coma. In general, barbiturates are indicated for the relief of the signs and symptoms of anxiety and for sedation, insomnia, pre-anesthesia, and the treatment of seizures. Contraindications and cautions for barbiturates. Allergy, previous history of addiction. Think about it. Remember, barbiturates are very addictive, right? So would we want, so for example, we have a patient in the facility and they have a history of alcohol abuse. Even though it's alcohol, that's still a history of abuse, of addiction. That, which means they're predisposed to addiction. Would it be a good idea to give them a barbiturate, especially when there are other better drugs on the market? So we don't want to give a barbiturate to a patient that has a history of addiction, regardless of the type of addiction. It doesn't have to specifically be barbiturate addiction, okay? So contraindication cautious, previous history of addiction to sedative hypnotic drugs, but I'm telling you now, it's not limited to sedative hypnotic drugs, because I've seen question on NCLEX before where they gave you that exact patient. It was a patient that had a history of alcohol abuse. Lane or manifest porphyria. Somebody look up this word, Porphyria. What is that? Porphyria? I must have known what it meant when I saw it, because I was thinking, what is that?
Oh, I didn't.
Disorders resulting in buildup of certain chemicals related to blood and cell plasma. It's a group of disorders caused by an accumulation of porphyrin, which helps hemoglobin proteins like
Okay. Hepatic impairment or nephritis, respiratory distress, severe respiratory dysfunction, pregnancy, lactation, congenital abnormalities have been noted in patients using barbiturates. Use in caution with patients with acute or chronic pain. Look at this, guys, because barbiturates can cause paradoxical, so it can cause the opposite of what we want to see happen. It can cause paradoxical excitement, masking other symptoms, seizure disorders. Guys, when a patient has a seizure, that is overexcitation of the CNS. We're not expecting to see that in a patient that is taking a barbiturate. So a seizure, wouldn't that be a paradoxical event? Right?
What? This is contrary, but isn't it used for treatment of seizures?
Did I read that wrong? Use with caution in patients, with acute or chronic pain. You're gonna use with caution in patients with seizure disorders. Yeah, we're not going to, not ever give it to a patient, but we're going to be very cautious when we do give it to a patient if they have seizure disorder. Be very cautious, yes. Chronic hepatic or cardiac or respiratory disease. Care should be taken with lactating women. Adverse effects of barbiturates. As previously stated, the adverse effects caused by barbiturates are more severe than those associated with the other newer sedative hypnotics. For this reason, barbiturates are no longer considered the mainstay for the treatment of anxiety. There are way better drugs on the market now. That's on the NCLEX. That's the NCLEX question. Make sure you know it. Barbiturates are not our first line treatment for anxiety. What is? Benzodiazepines. Very good. The most common adverse effects are related to general CNS depression. CNS effects: drowsiness, somnolence, lethargy, ataxia, vertigo, feeling of having a hangover. GI symptoms: nausea, vomiting, constipation. Cardiovascular effects: bradycardia, hypotension. Serious hypoventilation may occur, and respiratory depression and laryngeal spasms can result, especially if it's given IV. Hypersensitivity reactions include rash, serum sickness, and Stevens-Johnson syndrome. You better know this. You're going to see this again in Psych. It is an NCLEX question. This is deadly. This is lethal. Drug-drug interactions. Increased CNS depression results if these agents are taken with other CNS depressants. So again, guys, we're staying away from opioids, alcohol, antihistamines, tranquilizers. There's often an altered response to phenytoin, that's dilantin, if it's combined with barbiturates. This drug, guys, this phenytoin is given for what? Seizures. If barbiturates are combined with MAOIs, these are drugs that are given for depression. If they're given with MAOIs, increased serum levels can occur. And just so you guys know, because you guys are going to have to know this for Psych anyway, you can't give anything with MAOIs. Like literally nothing. Everything's contraindicated with MAOIs, and that's why we really don't like them. But some patients, like nothing else works, we have to try the MAOIs. But you literally can't give anything with MAOIs. Crazy. All right. The following drugs may not be, in addition, because of an enzyme induction effect of barbiturates in the liver, the following drugs may not be as effective as desired. So this whole list, all of these drugs that you see, if the patient's taking barbiturates, this whole list of drugs may not be as effective. Out of this list, who has a highlighter? Thank you. The most important ones that you guys need to know that I've seen on tests are these. Your oral anticoagulants, and that's important because the patient may need those anticoagulants so they don't have a clot, right? And so here they are taking the oral anticoagulants so they don't have a clot or another heart attack, but they don't realize that because they're taking the barbiturates, the oral anticoagulants aren't as effective. So you need to know that. If that patient is already taking an oral anticoagulant and the doctor orders a barbiturate, are you going to give it blindly or are you going to question that order and hold it? Very good. Digoxin. Digoxin is another important one. Remember, guys, digoxin, although it decreases the heart rate, it increases the contractility of the heart. So this is a very important medication that we need to work effectively. So if that patient's taking digoxin and the doctor orders a barbiturate, we are going to question that order. Antidepressants, whether it's a TCA, if the patient's on an antidepressant, especially TCA, but serotonin, SSRIs too, it may not be as effective. Why is that important? We don't want the patient to go, right? So here they are taking their antidepressants. We're thinking the patient's good, and they end up harming themselves or attempting to. Corticosteroids, that's important. If the patient has some type of inflammatory condition that they need to be taking those corticosteroids and they're not working. So we have to let the doctor know about that. And here's another big one that they ask about a lot. Oral contraceptives. That woman will mess around and get pregnant when she didn't want to if she's taking that and a barbiturates at the same time. So for that woman who's on oral contraceptives, for that time that she's on barbiturates, she's gonna have to switch to what? Barrier contraceptives, condoms. Very good. All right, guys, make sure you take a look at this on your own for phenobarbital. The one thing I will say when it comes to phenobarbital, the barbiturates, just think safety, 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 safety. Nursing considerations for barbiturates. Assess them for known allergies. Assess them for history of addiction to sedative hypnotic drugs. That's on NCLEX, make sure you know it. Impaired hepatic renal function, cardiac dysfunction, or respiratory dysfunction, because remember, it slows down the heart rate. It can slow down that breathing, right? Seizure disorders, chronic pain disorders, pregnancy, lactation, implementation. Do not administer barbiturates intraarterially. Do not mix IV drugs in solution with any other drugs. If you're giving barbiturates IV, it has to be only barbiturates in that line. Switch to oral forms as soon as possible. If you absolutely must give barbiturates IV, how are you going to give it?
Slowly.
Slowly. Taper dose gradually after long-term therapy. When it comes to CNS drugs, we never discontinue abruptly. Patient has to be tapered off. Key points. Barbiturates are an older class of drugs used as anxiolytics, sedatives, and hypnotics, and they are not the first-line treatment. What's the first-line treatment? Benzos. Very good. All right, other anxiolytic and hypnotic drugs. The first one, antihistamines. Drugs can fall under several different classes. So antihistamines do also fall under anxiolytic or hypnotic drugs. Why? They have sedating effects. Make sure you know that. Buspirone. It has no sedative, anticonvulsant, or muscle relaxant properties. It reduces signs and symptoms of anxiety without many of the CNS or adverse effects. And the rest of these drugs, you guys can read that on your own. Dalapon, I will cover that one with you. That's Ambien. Zolpidem. No, Zolpidem is the Ambien. Zolpidem is the Ambien, sorry guys. The Xalapon and Zolpidem, both of which causes sedation, they're used for short-term treatment of insomnia. NCLEX expects you to know that short-term. You do not give these medications long-term. Summary. Anxiolytics treat anxiety by depressing the CNS. Sedatives cause drowsiness, lethargy, and other effects. Hypnotics further depress the CNS. Benzodiazepines are used as anxiolytics and they cause drowsiness, lethargy, and other CNS effects. Barbiturates are drugs used as anxiolytics, sedatives, and hypnotics. They're associated with potentially serious adverse effects and they interact with many other drugs. They are not the first line treatment for anxiolytics. What's the first line treatment for anxiolytics? Oh my gosh, you guys make me so happy. Buspirone, another anxiolytic drug, does not cause sedation or muscle relaxation. And that's why I put a happy face right next to it so you can remember that. Zelplon and zolpidem affect melatonin levels in the brain, and that's how it causes sleep. But can they be given for long-term treatment? No, just short-term use. All right, I see you standing up back there. Okay, 10-minute break, and then we're going to start with antidepressant drugs. All right, guys, antidepressant agent. All of this stuff, you're going to see again in psych. Psych is very big. Guys, when you get into psych, they're very big on the pathophysiology and the pharmacology. Big time. All right, important terms. Affect. When you look at a person's affect, you should see, you know, have a general idea. Are they happy? Are they sad? Are they frustrated? There are certain conditions where a patient has flat affect and you can't tell, such as Parkinson, right? Depression. If you guys can get this concept through your brain, when it comes to questions on depression, you guys will get so many questions right. So please understand. All depression is anger, resentment, hostility turned towards self. And that's why if you get a test question on what is, okay, here's an example. If you get a test question about a patient that is in the inpatient facility and family member promised to come visit and they did not come, and the patient becomes enraged about that family member not showing up, and they throw something against the wall, or you know, they say something like they're really upset. Guess what? It's a good thing. It's not a good thing they threw something up against the wall, but the fact that they were upset that the family did not come, that means the medications are working. Because remember, depression is anger, hostility, resentment towards who? Self. So when you're depressed, I'm not good enough. Of course, such and such didn't come see me. I'm not worthy. But as soon as that depression starts to lift, that medication's working, I am worthy. How dare they say that they're coming to see me and they don't see me? I'm upset because I have value. Do you understand why it's a good thing that they get upset? Mm-hmm. So don't fall for it. Make sure you guys read those test questions very closely. All right, anyway. MAOIs, and you guys, remember I told you you can't take anything with MAOIs, you're about to see why. SSRIs, those are first line drugs for depression. They have the least side effects, least adverse effects, better efficacy. That's our first line, okay? They block the reuptake of serotonin and they increase the concentration in the synaptic cleft. They relieve depression, and they're not associated with anticholinergics or sympathomimetic effects. You know, I can't speak. TCAs, they block the reuptake of norepinephrine and serotonin. They relieve depression, but TCAs do have anticholinergic and sedative effects. Tyramine, an amine found in food that causes vasoconstriction and raises blood pressure. Ingesting foods high in tyramine while taking MAOIs poses a risk of severe hypertensive crisis. Any patient that's taking MAOI, they cannot eat foods high in tyramine. So we're going to go over that, the foods that are high in tyramine that you're going to have to teach that patient to avoid. So make sure you guys know these terms. Drug list, what are we on, number 3? 4. TCAs, that's the 4th one, your tricyclic antidepressants. Number 5, your MAOIs. Number 6, your SSRIs. And number 7, your other antidepressants. Remember, thank you. Bupropion, this also helps with cessation of smoking. That's very important for you to know. So if you have a patient that has depression, but they also want to stop smoking, this is a great choice that you would expect the doctor to order for the patient. All right, page 356, affect. Affect is a term that's used to refer to people's feelings in response to their environment, whether positive and pleasant or negative and unpleasant. Like I said, happy, sad, frustrated. Depression, you guys can look at that textbook definition. I told you what it is. Drug therapy. Antidepressants may be classified into 4 main groups. Your tricyclic antidepressants, which are your TCAs. Your monoamine oxidase inhibitors, which are your MAOIs. Your selective serotonin reuptake inhibitors, which are your SSRIs and SSNRIs. Let's start with the TCAs. All reduce the reuptake of 5-HT and norepinephrine into nerves. Because all TCAs are similarly effective, the choice of TCA depends on the patient's individual response. A patient who does not respond to one TCA may respond to another TCA within that same class. TCAs that are available include, and you guys see the list, make sure you have those on your drug card. Let's jump to page 358. TCAs are indicated for the relief of symptoms of depression. The sedative effects of these drugs may make them more effective in patients whose depression is characterized by anxiety and sleep disturbances. Some patients, guys, have depression where all they do is sleep all day. They got the curtains drawn, they don't want to get out of bed, all they do is sleep. But then you have some patients that have depression that have insomnia. So the TCAs, yes, they do have sedative effects, but that's not always a bad thing. It's a good thing for a patient that may also suffer from insomnia, okay? Look at this. The TCAs are what? Anticholinergic. Can't see, can't spin, can't pee, can't you know what? You better remember those signs and symptoms of the anticholinergics. Contraindications. Any allergies to TCAs? Recent myocardial infarction. If the patient's having a myelography within the next 24 to 48 hours. Myelomuscle, whenever you see ography to see or gram, they're using what? Dye. Okay? Look at this. Because of a possible drug-dye interaction with the dyes that's used in the study. So that is a contraindication if they're going to have a myelography within the next 24 to 48 hours. If they're on an MAOI, they cannot be on a TCA. If they're pregnant or lactating. If they have a pre-existing cardiovascular disorder, excuse me, or if they have any condition that would be exacerbated by anticholinergic effects, because remember, TCAs have anticholinergic effects. Here's your examples of conditions that could be exacerbated by anticholinergic effects. Angle closure glaucoma, urinary retention, prostate hypertrophy, GI or genital urinary surgery. Care should be taken with psychiatric patients who may exhibit a worsening of psychosis or paranoia, with manic depressive patients who may shift to a manic stage. Let's stop there because let's talk about this for a moment. Let's go back to the top where it says, care should be taken with psychiatric patients who may exhibit a worsening of psychosis or paranoia. If the patient has depression and they're getting this med, and you see they went from depression, but at least they were in touch with reality, to now psychosis, they're out of touch with reality, you better call that doctor because they're going to have to switch that patient meds. Okay, that med's not being effective. Or manic depressive patients. Manic depressive patients, so a patient, for example, a patient is bipolar that has stages where they're manic, they're happy, they're all over the place, then they're sad, they don't even want to get out the chair. Well, does it make sense to give a TCA if they're in the manic stages of the depression? No. Because the TCA is for what? The depression part, not the mania part. So we have to be careful with that. There's a black box warning on all of the TCAs, bringing attention to the risk of, how do I pronounce that word? Suicidality, especially in children. And NCLEX especially needs you to know this, adolescents and young adults. The adolescent part, that's the part they ask about the most. When it comes to antidepressants, they sometimes have a paradoxical effects on children, especially adolescents. The problem with the adolescents, guys, that part of their brain that's supposed to develop that they can kind of see in the future, it's past whatever the current problem they have, it's not developed yet. So for that adolescent, it's the end of the road. It's never going to get better. And so they're more likely, and it sounds weird because they're taking an antidepressant, but that same antidepressant may increase their risk for committing suicide. So be very careful. Look at this. This is also on NCLEX. What did I write? NCLEX, DC only 2-3 days work. I have no idea what I'm talking about. Let's see. It says caution should be used and the amount of drug dispensed at any given time should be limited with potentially suicidal patients. Okay, I know what I was trying to say. All right. So NCLEX has been known to give you a situation where you had a patient that was in the facility, they seem to have been improved, they're being discharged. What do you expect them to be discharged with? You only expect them to be discharged with 2, maybe 3 days worth of meds. Why? We expect them to follow up immediately with their psychiatrist, with their physician after they've been discharged, because if you send them home with 30 days of medication, what can they do? Just take it all and commit suicide. Okay, so it's very important when that patient's being discharged that they have 2, maybe 3 days of the medication, and you, as a nurse, you have to encourage them to follow up with their doctor. We're going to be cautious with a patient who has a history of seizures, hepatic or renal disease. Adverse effects. The CNS effects include sedation, sleep disturbances, fatigue, hallucination, disorientation, difficulty concentrating. Remember, guys, that the TCAs have anticholinergic effects such as dry mouth, constipation, nausea, vomiting, anorexia, increased salivation, diarrhea, cardiovascular effects, orthostatic hypotension, hypertension, arrhythmias. And as always, like any other drug that affects the CNS, abrupt cessation of TCAs can cause a big problem. What can they cause? Withdrawal syndrome that's characterized by nausea, headache, vertigo, malaise, and nightmares. You never stop these drugs abruptly, ever. Drug-drug interactions. If the TCAs were given with cimetidine, fluoxetine, or ranitidine, an increase in TCA levels results with increase in both the therapeutic and adverse effects. The combination of TCAs and anticoagulants leads to higher levels of the anticoagulants, which means that patient can what? Bleed to death, right? It can cause increased risk of bleeding. If TCAs are combined with sympathomimetics or clonidine, the risk of arrhythmias and hypertension is increased. Remember sympatho. Whenever you think of sympatho, you're thinking of speeding things up, heart rate going up, blood pressure going up to the point that the patient can have a stroke or an arrhythmia. The combination of TCA with MAOIs, remember, we don't give anything with MAOIs, but the combination of TCAs with MAOIs leads to a risk for severe hyperpyretic crisis, so that temperature, they're burning up alive, with severe convulsions, hypertensive episodes, and death. So are we ever going to give a TCA with an MAOI?
No.
No. This combination should be avoided. Nursing considerations for patients receiving TCAs, assess them for allergies, impaired liver kidney function, glaucoma, BPH, cardiac dysfunction, GI obstruction, surgery, recent myocardial infarction, pregnancy lactation, assess them for history of seizure disorders, history of psychiatric problems, including suicidal thoughts, Any myelography scheduled within the next 24 to 48 hours. Excuse me, the past 24 hours or 48 hours. So let me stop right there because I want to make sure I make this clear. If the patients had a myelography within the past 24 hours, obviously that dye's still in their blood, right? Or they're scheduled to have one within the next 48 hours, okay? Or if they're taking the MAOIs. Implementation rationale, you're gonna limit drug access if the patient's suicidal. Ding, 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 yes. You want to maintain the initial dose for 4 to 8 weeks to evaluate therapeutic effect, and you have to teach the patient that rationale. That's another biggie that's big on NCLEX. They expect you to know that you have to teach that patient that it is going to take several weeks before you start to feel a therapeutic effect. Because if you don't teach them that, remember, the patient has anger, aggression, resentment, all those bad feelings towards self. So if you don't teach them that it's going to take several weeks before they have a therapeutic level of this drug, they're going to say to themselves, how come Susie, Mary, and Mike are all taking the same medication and they're feeling better, but I'm not? I knew it. I'm a loser. I knew it. Something's wrong with me. And then that'll be enough that they might want to try to kill themselves. So you have to warn them it's going to take weeks, so be patient. And by the way, that time frame for therapeutic effects, that's for antidepressants across the board, whether we're talking about TCAs, SSRIs, MAOIs, you name it, okay? None of them work immediately. Administer a major portion of the dose at bedtime if drowsiness and anticholinergic effects are severe, because we want them to sleep. And it also prevents falls because remember, I'm sorry, I just lost my train of thought. It'll come back to me. Anyway, you want to reduce dose if minor effects occur and discontinue the drug. How? Slowly. If the patient has to be discontinued, they're going to be weaned off. You never stop abruptly. Key points. Affect. This is a term that refers to the feelings that people experience when they respond emotionally. Depression, remember guys, that is turned towards self. It's an affective disorder characterized by inappropriate sadness, despair, hopelessness. Turned towards who? Self. Very good. Next, monoamine oxidase inhibitor. Those are your MAOIs, and they are not the first or even second choice of antidepressants. MAOIs irreversibly inhibit MAO, an enzyme found in many nerves and other tissues. They're used rarely because they require a specific dietary regimen to prevent toxicity. Remember, they can't eat anything high in tyramine. There are some patients, however, who only seem to respond to these particular drugs, so they remain available. Agents still in use include, and they give you the list of your MAOIs, make sure you know them. Therapeutic agents and indications, blocking the breakdown of the biogenic amines, norepinephrine, dopamine, and 5-HT, allows these amines to accumulate in the synaptic cleft, etc. I've never seen any test questions on that, so I'm not going to make you guys know it. You guys can read that on your own. But look at this. The MAOIs are generally indicated for treatment of the signs and symptoms of depression. Look at this, guys. In patients who cannot tolerate or do not respond to other safer antidepressants. So guys, this is not our first or even our second line of treatment for last resort, exactly, for depression. And to be honest, it's like our second to last resort because our last resort is that's I'm gonna get canceled. It's not like, you know, in the 50s and 60s, it really was like shock. It's not like that anymore, but shock therapy, that is our last resort. I can't believe I did that. All right, let's keep it moving, guys. Never happened. Contraindication precautions. I can see it now. Watch. Go in the comments. You're gonna see it. Yeah, all right. Contraindication cautions. Allergies. There's a risk of hypersensitivity reactions, pheochromocytoma, because of the sudden increase in the norepinephrine levels, cardiovascular disease, any known abnormal CNS vessels or defects, that's going to be a contraindication. A history of headaches can also be a contraindication. If the patient has a renal hepatic disease, if they had a myelography within the past 24 hours, or there's one scheduled within the next 48 hours. In addition, caution should be used with psychiatric patients who could be overstimulated, because remember, if they have depression, they're like this, their mind is like this, right? We're trying to elevate them. But if that med works a little bit too much, it could be, they cause overstimulation or a shift to manic phase as a result of the stimulation associated with MAOIs. There's a black box warning on all drugs of this class to bring awareness to possible risk of suicidality in patients using these drugs, especially with children, adolescents, and young adults. You're seeing this again, and that's across the board for antidepressants, guys. Care should also be taken with patients who are soon to undergo elective surgery because of the potential for unexpected effects with norepinephrine accumulation during the stress reaction. Remember, when you're stressed, whether it's a physical stress, such as surgery or sick, or an emotional stress or psychological stress, remember your norepinephrine increases. Remember the story I told you about Puerto Rico? There you go. During stress reaction and with female patients who are pregnant or breastfeeding. Adverse effects of MAOIs. The MAOIs are associated with some adverse effects, more of which are fatal than most of the other antidepressants. Deadly. Dizziness, excitation, nervousness, mania, hyperreflexia, tremors, confusion, insomnia, agitation, and blurred vision may occur. MAOIs can cause liver toxicity. You guys can take a look at the GI effects and the cardiovascular effects, but I'm going to bring this to your attention. Potentially fatal hypertensive crisis. The last condition is characterized by occipital headache. These are the signs and symptoms of that hypertensive crisis that often has been seen on NCLEX as a select all that applies. What are those signs and symptoms? Occipital headache, palpitations, neck stiffness, nausea, vomiting, sweating, dilated pupils, photophobia, tachycardia, and chest pain. It may progress to intracranial bleeding and fatal stroke. Drug-drug interactions for MAOIs. Look at everyone on the side. Everything. Everything causes a drug-drug interaction with MAOIs. Drug interactions with MAOIs with other antidepressants include increased risk of hypertensive crisis, coma, severe convulsions with TCA, increased risk of potentially life-threatening serotonin syndrome with SSRIs. On the side, I wrote this. You definitely, I promise you, it's going to be a test question when you get to psych. The signs and symptoms of your SSRIs. Increased heart rate, blood pressure, muscle rigidity, confusion, agitation, restlessness, sweating, diarrhea. The exact timing will vary, but a period of 6 weeks after stopping an SSRI may be needed before beginning therapy with MAOI. So it's not enough that, let's say that patient got weaned off the MAOI, right? It's still going to stay in their system. So we still have to wait a solid 6 weeks after they stop that MAOI before they can go and start the SSRI. Otherwise, they can get serotonin syndrome. Again, signs and symptoms of serotonin syndrome: increased heart rate, increased blood pressure, muscle rigidity, confusion, agitation, restlessness, sweating, and diarrhea. I didn't write this just for the fun of it. All right, very important table, table 21.3, tyramine containing foods. If a patient is on MAOI, they shouldn't have any of these. And I underlined the ones that show up on NCLEX the most. But guys, I don't write NCLEX. So don't say, Professor D, you told me to only know these ones. I don't know what's going to be on there. Aged cheeses, red wine, smoked or pickled meats, salami, pepperoni, soy sauce. There was a test question about a patient that was on an MAOI. It was a select all that applies. Which food would you tell them to avoid? And there was a type of cheese on it. I'm trying to remember, but it wasn't one of them because it's not aged. What's that cheese that looks like the
Blue cheese.
Feta.
Feta, goat cheese.
No, I think cottage.
Cottage.
It's cottage. What is it?
It's cheese, but it looks like rotten milk.
It's goo. Well, it's called cottage cheese. I don't know. Anyway, the point is, cottage cheese
It's not it.
is not on that list, so don't be tricked. Don't see cheese and just, oh, that's the answer. Remember, it has to be aged cheese. And when I saw it, I'm like, so I had to like do some research, and cottage cheese is not aged, I guess. I don't know. But the point is, cottage cheese isn't on there. Don't choose it.
It's like byproduct of cheese making.
It's what?
It's the byproduct of cheese making, so it's like the
Yeah,
unused.
before-
It's really.
I thought that was so unfair to have on that list, but it's very unfair. Anyway. Drug food interactions. Tyramine and other pressure amines that are found in food, which are normally broken down by MAO enzymes in the GI tract, may be absorbed in high concentrations in the presence of MAOIs, resulting in increased blood pressure. So if you're taking an MAOI, but you're eating foods high in tyramine, that can cause your blood pressure to go high. You're now in hypertensive crisis. Okay? Patients who take MAOI should avoid the tyramine-containing foods. And here are the list. Make sure you know them. Don't say I didn't warn you. Nursing considerations for patients taking MAOIs. We're again going to assess them for allergies, impaired liver, kidney function, cardiac dysfunction, GU obstruction, surgery, including elective surgery, seizure disorders, psych conditions, or suicidality, having a myelography within the past 24 hours or scheduled for the next 24 hours, pregnant or breastfeeding. Implementation rationale. You're going to limit drug access to potentially suicidal patient. Monitor the patient for 2 to 6 weeks to make sure the onset of the full therapeutic effects. You're going to monitor blood pressure and orthostatic blood pressure carefully and to arrange for a slower increase in dose as needed. Monitor their liver function. Discontinue drug and monitor the patient carefully at any complaint of severe headache. What are we worried about? Severe hypertension, stroke, right? So where they say discontinue the drug, if you are going to give it, that means you're going to hold it and do what? Call the doctor. Okay. Have phentolamine or another adrenergic blocker on standby in case the patient has hypertensive crisis. Provide comfort measures. You're going to provide a list of potential drug-food interactions that can cause severe toxicity. Provide a diet that's low in tyramine-containing foods. Key points. Patients taking MAOIs need to avoid foods high in tyramine to prevent serious increase in blood pressure and hypertensive crises. And they save the best for last. SSRIs. Please tell me this is the last one. Okay, we'll stop with the, I'm gonna finish up the SSRIs and then we'll continue next week with the rest. Yeah, I can take it more. All right, so selective serotonin reuptake inhibitors. These are #1 choice for antidepressants. And SSRI antidepressant drugs specifically block the reuptake of 5-HT with little to no known effects on norepinephrine. Because SSRIs do not have the many adverse effects associated with TCAs and MAOIs, they are a better choice for many patients. Therapeutic actions and indications. SSRIs are indicated for the treatment of depression, OCD, panic attacks, bulimia, premenstrual dysphoric disorder, post-traumatic stress disorder, social phobias, and social anxiety disorders. Yes, you have to know the indications. Again, a period of up to 4 weeks is necessary for realization of full therapeutic effects. You teach that to the patient. Otherwise, they're going to think that they should start feeling better immediately. Contraindications and cautions for SSRIs. Allergy, hepatic dysfunction, renal dysfunction, severely depressed or suicidal patients, especially children, adolescent, and young adults. Pregnancy. If the woman's breastfeeding, a different method of breastfeeding the baby should be selected if an SSRI is required by the mother because it passes through the breast milk. Adverse effects. CNS effects include drowsiness, dizziness, anxiety, tremor. You guys can take a look at the GI effects, respiratory changes. Look at this. SSRIs may also cause serious intraocular pressure changes if used in patients with untreated narrow angle glaucoma. Other reported effects are sweating, rash, fever, pruritus. Recent studies have linked the incidence of suicidal ideation and suicidal attempts to the use of these drugs in who? Pediatric and adolescents. So we have to watch these kids so much more closer than with adults. My kids that I diagnosed with major depression disorder, I send them right over to Psych. I don't even prescribe those medications. They have to be followed so closely. All right, drug-drug interactions. Where? No help? Oh, no herbs. Because of the risk of serotonin syndrome, I already gave you the sign and symptom of serotonin syndrome, guys. Because of the risk of serotonin syndrome, if SSRIs are taken with MAOIs, this combination should be what? Avoided. It is on NCLEX. You better know this. The exact timing will vary, but a period of 6 weeks after stopping SSRI may be needed before beginning therapy with an MAOI. Serotonin syndrome, a serious to potentially fatal reaction can occur if these drugs are combined with any drug or herb that increases 5-HT levels. Other SSRIs, serotonin norepinephrine reuptake inhibitors, St. John worts, or triptans. There's an increased risk of bleeding if these drugs are combined with aspirins, NSAIDs, antiplatelet drugs, or drugs that affect coagulation. You absolutely must know that as well. Let's look at box 21.4, excuse me. When you guys get to Psych, open your book back, your pharmacology book back to this chapter when you guys get to the present. I promise you, all of these that you see I put NCLEX next to, those are going to be test questions. So go back and review this. Patients being treated with SSRIs are at an increased risk of developing a severe reaction, including serotonin syndrome, as well as an increased sensitivity to light if they're also taking St. John's worts. Patients taking SSRI shouldn't be taking any herbs, period. Because this herbal therapy is often used to self-treat depression, it is important to forewarn any patient who's taking an SSRI not to combine it with taking St. John's worts. Also caution patients that there's an increased risk of seizures if evening primrose, thank you, is used with antidepressants, and patients should be cautioned against this combination. Interactions have also been reported when antidepressants are combined with ginkgo, ginseng, and valerian. Patients should be cautioned against using these herbs while taking antidepressants. Prototype summary, fluoxetine. Make sure you read that, but one thing I'm gonna point out to you, fluoxetine is a great antidepressant for it, because many times when it comes to Psych, these patients have comorbidities. So if you have a patient that's suffering from depression, also bulimia, this is a drug that helps treat bulimia as well, and NCLEX expects you to know that. Nursing considerations for patients receiving SSRIs or SNRIs. Again, you're going to assess them for allergy, severe depression or suicidality, angle closure glaucoma, bipolar disorder. Why? Because we're concerned about that panic phase. Impaired liver kidney function, diabetes, pregnancy or breastfeeding. Implementation rationale. Arrange for a lower dose in elderly patients and those with renal and hepatic impairment. Why? That medication is going to stay in the body a lot longer. And so they're at a higher risk for getting a toxic effect. So they're only going to need a lower amount of that medication. Monitor the patient for up to 4 weeks to ascertain the onset of full therapeutic effect before adjusting the dose. It has to be at least 4 weeks before it's even considered to adjust the dose, because you're really not going to see anything. I say really like 6 weeks. The book says 4. But 4 to 6 weeks, that's really when you're going to start to see the effects. Establish suicide precautions for severely depressed patients. What does that mean? One-on-one. They can't even go to the bathroom by themselves. Limit the quantity of the drug dispensed. No more, I'm pushing it when I say 3 days, no more than 3 days worth of medication if they're being discharged. Administer the drug once a day in the morning. Remember, the drug is supposed to elevate the mood, bring things up. So why would we give it at night where it would make them stay up? We want to give it to them in the morning so it has effect on them during the day. You're going to teach them while they're taking this drug to use barrier methods such as what? Condoms, very good. Prevent pregnancy. This drug can cause serious fatal abnormalities. Provide comfort measures. This includes voiding before dosing, instituting a bowel program, taking food with the drug if GI upset is severe, control lighting, instruct the patient about the need for periodic evaluation and monitoring. You're going to monitor for the effects of the SSRIs and the SNRIs, those signs and symptoms. Remember, there's a risk of serotonin syndrome with both classification of medication. So be very wary if you get a test question and they tell you the patient's on an SSRI and you're seeing all of those or a couple of those signs and symptoms of serotonin syndrome. Teach them to avoid pregnancy. Page 367, this is a case study, patients getting fluoxetine, which is an SSRI. What are some things you're going to keep in mind? You're going to give the drug in the morning, have the patient void before giving them the medication. Safety, make sure side rails are up. Again, suggest barrier contraceptives such as condom. You want to limit dosing so they don't take the whole thing and kill themselves. Teach them in advance. It's going to take at least 4 weeks before they start to see a therapeutic level. Again, drugs should be taken once a day in the morning. Take with food if they have an upset stomach. Again, it can take as long as 4 weeks before you start to feel the full effect of the drug. Take the drug every day as ordered. And they go over the common side effects. You guys can read that on your own. This, I'm pointing out because men will mess around and not take their medication because of this. So this is something that has to be discussed with the patient. Sexual dysfunction and flu-like symptoms. I don't know why I put the arrow on the flu-like symptoms because it's a sexual dysfunction that they stop taking the drug for. They'd rather be sick as a dog, feeling like they're gonna die. Yeah, before they lose that ability, okay? Teach them that these effects may be temporary. Consult with your healthcare provider if these conditions become bothersome, but under no means stop taking this medication abruptly. Let us know. Tell your doctors, nurses, and other healthcare providers that you're taking this drug. Do not take this drug during pregnancy. Use barrier contraception. Key points. The SSRIs prevent the reuptake of serotonin. SSRIs are not associated with many of the CNS, cardiovascular, and anticholinergic effects of the other antidepressants. And that's why SSRIs are first-line drugs for depression. Combination of SSRIs with other SSRIs or with other drugs that are known to increase 5-HT levels increase the risk of serotonin syndrome. You better know those symptoms of serotonin syndrome. Caution should be used if any of these drugs are combined with other drugs known to affect bleeding, such as anticoagulants. So we'll stop here and we'll start here next week, okay?